Hi everyone, hope you're all doing good. In this video, we are going to discuss about rupture uterus. So, what is rupture uterus? It is the complete division of all three layers of uterus. Okay, we know what are the three layers of uterus? It is the endometrium, which is the inner epithelium layer, and the middle layer is the myometrium, which is the smooth muscle layer, and finally we have the perimetrium or else the serosa as well, right? Okay. Now, uterine rupture is an important obstetric emergency because there is a high risk of maternal mortality and morbidity as well. Okay. So, we will see another term that is related to uterine rupture, which is uterine dehiscence. Okay. So, uterine dehiscence means there is incomplete division of uterus. That means the division is not going to penetrate through all the three layers. Okay. So, you will be able to see a uterine window if you open up the uterus. Okay. So, means uterine window means there will be a opening in the uterus as soon as you open the abdominal layers through which the fetus can be seen. Okay. So, opening through which the fetus can be seen. Okay. Sometimes this can be an occult finding also in an asymptomatic patient. Okay. So, this is a picture of uterine window that has been opened up during surgery. You are able to see that there is a defect in the uterine wall and the membranes has come out. Okay. Before giving the incision itself, they have seen that the membranes have been come out. Now, we will see what are the causes of uterine rupture. Okay. Causes of uterine rupture can be happening in case of scarred uterus, but yes, this may be new to you, that rupture in case of unscarred uterus is also possible, right? So, we will see what are the causes of scarred uterus. Okay. So, definitely we know it can be a previous cesarean section scar. Okay. So, this can be a lower segment cesarean section scar or a classical or a low vertical scar, right? Whereas sometimes there can be a scar in the uterus due to myomectomy also, or there can be a history of hysterectomy and when there was too vigorous curettage as well. Okay. Now, coming to unscarred uterus, the causes can be further classified into spontaneous causes of rupture of unscarred uterus and iatrogenic causes of rupture of unscarred uterus. Okay. So, the spontaneous causes may include causes like trauma or when she is a grand multi, okay, or there were congenital anomalies, placenta accreta spectrum, okay, and there was genetic disorders. Okay. Suppose there was genetic disorder like example is Ehlers-Danlos syndrome. Okay. Then if there was overstretching of the uterus, like overstretching can happen in polyhydramnios or weight of the baby is 4 kilograms like that, and it can also be associated when the gestational age is more than 40 weeks or there is a increased maternal age, contracted pelvis which can result in obstructed labor and cornual pregnancy. Okay. So, these are the causes of spontaneous rupture of unscarred uterus. So, we will see some iatrogenic causes of unscarred uterus. So this can happen while you are attempting to perform versions like external cephalic version or internal podalic version, or when there was a difficult forceps delivery, or when you gave a manual pressure on the fundus. There was induction of labor which was prolonged. Then sometimes augmentation of labor with oxytocin can also cause rupture of uterus. Clear? So that's why we always say while you are augmenting the labor with oxytocin, 1-to-1 monitoring is needed. Okay. So it is also important that you should examine any antenatal woman that is coming to you from the very first checkup to examine the abdomen to look for any uterine scars that she has, okay, any abdominal scars she has, and you have to get her proper history, okay, right. Now, if you take rupture uterus, the incidence is increased nowadays because people are attempting to do TOLAC, that is trial of labor after cesarean section, okay, and this risk is 15 to 30 times higher when people are having a history of cesarean section, okay. So, the cesarean section scars like classical cesarean section has a risk around 4 to 9% for uterine rupture, and in case of low transverse incisions, the risk is going to be between 0.2 to 1.5%. Clear? Right. And also, the number of cesarean sections would also increase the risk, right? So, when you have one previous cesarean section, there is 1% risk, and if there is a history of 2 previous cesarean sections, then the risk increases up to 3.9%. Clear? And the risk of uterine rupture is more in developing countries than developed countries, okay. Now, depending upon the timing of rupture, the site of rupture can also vary, okay. So, that means when the rupture is happening during pregnancy, mostly the rupture can happen in the upper segment of uterus, okay. And if it occurs during labor, it can either occur in lower uterine segment or upper uterine segment, but it is most commonly seen to occur in the lower segment than the upper segment, okay, because the lower segment is thinned out, okay, especially in case of prolonged labor or obstructed labor, right. And sometimes when a rupture occurs in non-obstructed uterus, then it happens mostly in the fundus region. Clear? Right. Now, we will see the clinical findings. So, clinical findings of dehiscence and rupture. First, we will see dehiscence. So, dehiscence rupture, as I told you already, it is usually diagnosed on the table, and you have to know that there is no hemorrhage or shock, and there is no need for hysterectomy as well. As you see this, don't rush to do hysterectomy in that woman, and there is no risk for the fetus also, okay, there is no fetal death or a change in FHR or anything, right. And for the mother also, there is no complication, no maternal morbidity or mortality, okay, and the vitals will be stable for the mother as well, right. Now, we will see rupture. See, presentation of rupture in the mother depends upon 3 factors, okay. So, it depends upon whether the woman received epidural or not, okay. Then it is a scarred uterus or unscarred uterus, and where is the location of rupture. Okay. Now we will see the difference of presentation between the Now we will see the difference in presentation of rupture uterus in a scarred uterus and an unscarred uterus. Okay. So in scarred uterus, we can have fetal bradycardia, deceleration of FHR, that can be a late deceleration or variable deceleration. Then there can be associated vaginal bleeding, persistent abdominal pain, or hematuria as well. Okay. Whereas in an unscarred uterus, there is cessation of contractions suddenly. Okay. Cessation of contractions suddenly, as well as there is cessation of abdominal pain in the mother. Okay. What she will feel is, she will be feeling sudden giving away type of sensation. Okay. There can be associated tachycardia or hypotension, and hematuria is also possible. There can be loss of uterine contour as soon as the rupture has occurred, right? Then there is loss of fetal station if you attempt to perform vaginal examination, and the fetal parts will be very easily palpable because the fetus is not anymore lying in the uterus, it is come into the abdominal cavity, right? So you will be able to palpate the fetus easily. Then on doing pervaginal examination, as I have already told, there will be receding of the fetal station, and apart from that there can be vaginal bleeding. Clear? Right. Now we will see what are the complications of rupture uterus. So complications of rupture uterus may include, there can be extension of the tear. Okay. So extension of the tears to vagina or cervix or sometimes even the bladder. Okay. And there can be rupture of the broad ligaments, that is, they will be forming a broad ligament, hematoma. There can be tearing of uterine vessels. There can be increased risk of intra-abdominal bleeding. Because of the intra-abdominal bleeding, there will be, yes, hemorrhagic shock as well, and complications of shock like DIC, acute kidney injury can also arise. And then for the fetus also there is a higher risk of mortality, or there is a risk of hypoxic ischemic encephalopathy as well. Okay. And most of these conditions are also associated with maternal morbidity and mortality. Clear? Right. Now we have to know how to evaluate the mother. So evaluation can be obtained by putting a by obtaining a corticotocogram, where you will be seeing a non-reassuring fetal heart rate pattern. Okay. And there is change in the contraction pattern in the tocodynamometer as well. Okay. So other associated investigations you have to send when there is a rupture uterus include, you have to send hemoglobin or hematocrit, and you have to send the coagulation profile, and USG should be done if patient is stable. Okay, and while doing USG, also rule out other causes of hemorrhage like placenta, previa or abruption as well, and you have to check if there is any abnormality in the uterine wall, any hematoma is present next to the previous scarred area, and there can also be free fluid in the peritoneum or fetal parts that are present outside the uterus. Okay. So, how we are going to manage this condition? So, management of this condition, since this is an obstetric emergency, action should be immediate. Okay. So, you should do an immediate action, because any delay in delivery, resuscitation or surgery can lead to increased risk of maternal as well as fetal mortality and morbidity, right? Then, what is the surgery you will do? You will do an emergency cesarean section with or without explorative laparotomy. Okay, and simultaneously have to treat the maternal hemorrhage that is happening also, right? Okay. Now, we will see what are the resuscitation steps you should do. You should get access of a large IV bore cannula, or sometimes central venous access can also be got. You have to do infusion of ringer lactate or blood transfusion as needed. And regarding surgery, you can give a midline incision while doing surgery, because there are certain advantages like better exposure, and it shortens the time interval between the incision and delivery as well. Clear? And then, if it is a small rupture, you can go for repair of the defect. Okay. Suppose if it is a large rupture significant enough to cause hemodynamic instability, then you have to prefer doing hysterectomy. Clear? Yes. We will see some of the important differential diagnosis of uterine rupture. Okay. So, differential diagnosis conditions includes, it can be a blood issue, or there can be placenta previa or placental abruption. Okay. Now, let us also know about the risk of maternal mortality in a scarred and unscarred uterus. Okay. So, risk of repeating, cut down that last line. So, when you take maternal mortality rate in scarred uterus, it is about 0.1% only. Okay. Whereas in unscarred uterus, this arises to 10%. See, the risk is more with unscarred uterus. Clear? And also, when you take the neonatal mortality rate also, in a scarred uterus, this is around 2%, whereas in an unscarred uterus, this is around 10% again. Okay? And then, the incidence of repeat rupture in next pregnancy can be anywhere between 33 to 100%. So that much significance it has. Okay, right. So with this one, we are completing the topic about uterine rupture. Hope this video has helped you. So until we meet in the next video, take care, happy learning and bye-bye.